Alô? Tá saindo som? Tá saindo som aí?
Agora tá.
Alô? Tá saindo som?
Agora tá certo.
Tá saindo som aí? Tá dando reverberação.
Agora tá.
Alô? Tá saindo som? Tá saindo som aí? Tá dando reverberação. Teste, som, testando, testando, teste, teste, som, testando. Só que vai caminhar um pouco. Tá bom, pode continuar. Pode aumentar a tela. Continuar. So, I hope. Well, is it okay? Okay, so we're back. So when you have a cluster randomized design, and a stepwise is a form of cluster randomized design, we need to be aware of the two sources of variance, because now we have clusters, not each individual. So any individuals are correlated to each other within each cluster. Example, if you live in the same neighborhood, in any city in Brazil, chances are that you're going to have the same socio-demographic background. And the socio-demographic background, for instance, is very important for some of your behaviors, which are related to health. So people tend to correlate with each other when they are in close proximity, either physically, or structurally, or organizationally, or spiritually, emotionally, any way, shape, or form. Well, imagine if you are patients of the very same clinic, and I'm trying to implement a new strategy, a new treatment protocol across hundreds of clinics or dozens of clinics, and then I have treatment and control clinics out of that group. Evidently, the patients in the same clinic, we have the same doctors, they have the same director of the clinic, the same administrator, the same nurse, and they are somehow clustered within themselves because what they receive from the healthcare service is very similar, too similar in that way. So that's what we call the intra-cluster correlation coefficient, is the variance a proportion of the variance between clusters, the means of the cluster. The mean for one cluster is different from the mean of the other cluster. That variance is called between cluster. And the difference between each individual within the cluster and the mean of that cluster. So that's a within variance. So these two sources of variance are combined, and therefore we need to kind of understand how they operate, and they're going to affect everything you calculate. Remember that when you calculate sample size, in a simple, let's say simple random sample to create a survey or a sample, you always have some kind of find the x, where the formula is around the variance of the simple random sample, okay? So in that formula, you have a sigma, which is your variance that's always in a way divided by n with the square root of that. Remember that? Remember that? So that's your proportion. You're going to try to find the variance of the proportion. Then you solve for the value that you're trying to solve, the x, the p in this case, to find out what your sample size is going to be. You solve for n actually, for the sample size. You know p, you know what the sigma is, and therefore you solve for that. Well, that sigma is going to be broken down into pieces, a larger variance than in traditional simple random. So when you do a clinically controlled randomized trial that's not clustered, your sigma is only one sigma, one source of variance, which is the difference between each individual, the average distance between each individual and the mean of the whole sample. Okay, here I have two sources of variance. I think I explained as much, but do some reading on this, and that has importance, like I've showed before to you in the outcome measure variance, how they affect your look at each group that you randomize into, like cluster randomize or randomized groups into clusters, right? So that's how it's affected. So it affects your sample size calculation. It affects your analysis tremendously. If you overlook the fact you have two sources of variance and assume a common sigma, a common variance, you will underestimate the size of that variance. So if you put that statistic in the analysis, that statistic will be bigger than it should be. So you falsify your probability of making a type 1 error. Type 1 error is when you say, hey, there is a real difference. I accept the alternative hypothesis and deny the null hypothesis. Well, in fact, the null hypothesis was true. So that's a huge problem. So we're going to see how that's affecting the analysis of the stepwise cluster design. Also, in the calculation of sample size, you need to take this effect, which you call a design effect, attributed to the clustering. Okay, and that is very simple. You take a random sample for your traditional simple random sample, and you multiply by the design effect, which is basically this formula I gave it to you last time. You should have read a little bit about it. If not, I'll give it to you again. Unfortunately, something's coming between. Let me just correct here. Yeah, now we can do it. So I want you to be able to read this, even though you're a lecturer, you're going to see that easy, I think. Okay? So, in a nutshell, this important component, which is the whole row, the row is one, no variation within cluster observation, you get the cluster are the same, and within cluster 0, the sample size required for the cluster is multiplied by a factor of row. Okay, so if the row is 1, then you just multiply by 1. So, but in general, the rule is you calculate the sample size for a randomized trial, traditional randomized trial, and you multiply by this factor here, 1 plus n minus 1 over b, multiplied by rho. Okay. So clustering effect, we went over this. Just wanted to show to you that selection bias can be introduced into clusters. How you sample the cluster is not different than sampling in randomized across group. But here you have a chance, to make selection bias. We're going to give an example in stepwise later on. So let's get into the rollout design specifically. I'm going to skip this initial part. I want you to read it and study there are variations of this concept of rollout design, because the stepwise is really, you release an intervention little by little over time. So everybody's controlling the beginning, little by little release the intervention for different subgroups or clusters within periods. So you actually randomize on the period, on the time frame that you have, you randomize into that, but each cluster or group of clusters associated with each period, because you randomly allocate them a priori before you start the trial. And ideally, that's another thing, you need to engage people within the clusters initially, early on, before even randomize the clusters on time periods, okay? So, but here is the rollout design in general, very similar to the stepwise. They all have these characteristics of everybody starting as a control, and we call control period, and then intervention period that's just going left to right and bottom to up. Okay, that's a stepwise design right there. We're going to go in more details. There are alternative names for this stepwise design: delayed intervention, delayed treatment, waiting list, phased implementation, staggered implementation, crossover. Each one of them have a little bit of a little difference in the way you interpret the allocation and how you measure the outcomes. So the advantage of the rollout designs, the big one is really ethical. Once, way back in time, I tried to evaluate the intervention with a cluster randomized design on a whole state. And then the mayors of the cities, which are only considered clusters at the beginning, which is all of them, could be in a stepwise, but at that point, it was a traditional cluster randomized design. They did not accept to be clustered into the control group. They wanted the treatment. So that means if I force that, I'll be totally unethical, politically incorrect, and that will take the money away. So sometimes it's impossible to do a traditional cluster randomized design or any type of design that involves randomization the traditional way, treatment control. So by saying, hey, everybody's going to get the intervention at the very end, that's what this stepwise does. And we start everybody's control. And over time, little by little, each unit is, and the unit could be individual or could be a cluster. In this case, the cluster stepwise cluster randomized design will turn into the treatment. Everybody's going to get the treatment. Decision on which subregion gets intervention first becomes fair. Go first, immediate access to potentially beneficial program. Go later, program potentially improved through experience. So you can always have this argument, ethical, that even though everybody starts control, everybody's going to get the intervention. Those who take the intervention longer may benefit more as a fact, but also it may be that intervention wins off over time, becomes weaker because people do not follow the rules anymore. They don't like the standards anymore, and they are tired of doing the right thing. I've seen it happen. So you can go either way. Over time, the interventions, the clusters who received the intervention earlier may become too tired, too inefficient in delivering the intervention. And over time, the quality of the intervention goes down, and the outcome should reflect that. But also you can see the reverse. If the stepwise design is done in a shorter period, we're going to see that later again. Then it may be those who took the intervention longer have the greatest benefit at the end of the period that you observe. But it's a little bit more in line with ethics and politics of traditional intervention delivery in a health systems or public health setting. And remember, this to me is the most important design for you, because when I started this role about 20 years ago around rollout designs, I promoted a lot of conference around that. I had the power at that point. I was the head of a very large actually research program at the federal government of the United States. And so we released tons of money, close to $1 billion over 10 years. $1 billion, yes, you're right, it's 5 billion reais, okay, to universities and partners to implement applied intervention research. And I promoted a specific conference to discuss the methodology of rollout designs and other type of evaluations, because we need more evaluation in the US. And guess what? At that point in time, we've done an assessment in Brazil and found out that 99% of the publication Science of Public Health was about cross-section of surveys. There was nobody evaluating intervention, so we created a project to evaluate physical activity intervention went very well, and that was 47 publication peer-reviewed journal, including a series on Lancet, a big journal, on the physical activity programs of Brazil. But that was it. After that, it fizzled again, and very little. So I'm bringing this to you because I want you to take advantage of this rollout designs, as well as the other methods I'm going to show you today, and I'm already showing you in the past 4 or 5 days, to be aggressive in pursuing evaluation of programs and intervention. So I'm going to list again very quickly the advantage of rollout design. Step right is one of them. Communities don't hold equipoise about a prevention program rollout, minimize holding of potential beneficial intervention. So that's what the example I gave it to you before on Missouri, the state of Missouri, when I was a state epidemiologist there 25 years ago. And basically say, no, not in my backyard. If you want to intervene in my city. There's no BS of control. I don't want to be controlled. So that's politics, that's the real life. And the whole money was tied to the CDC. The CDC said, no way, you can't do that if the state doesn't want. Statistical advantage, improvement over alternative design. You avoid the readiness bias of non-randomized community studies, just better than a non-randomized design for sure. We're still randomizing cluster on time. Okay, we're going to see that as we go about. It's statistically more efficient compared to weighted list design, which is a form of stepwise, but the traditional stepwise are a little bit better than a weighted listed. I'll show some example. It is still a true experiment, producing a much stronger causal inference than an observational design. Remember, natural experiments can also take advantage of cohorts, existing cohorts, and prospective cohort, to try to understand the relationship between intervention and outcome, health outcome. But this is better. A wide range of design choice. There's a lot of variation on these themes of rollout design, especially the stepwise. I'm going to skip the rollout. I want you to study. We're going to focus on all of them, kind of a variation of the stepwise, but I'm going to give you the traditional stepwise, a more formal view, so you can retrospectively look back. Okay, so the rationale I already gave it to you. I'm not going to read it again, but I would say there is a primary rationale. It's that the ethical concern is the one that really carries everything. The example I gave from Missouri. People just don't like to be controlled. If they have power, like politicians, ethicists, other colleagues at epidemiologists, they may not like that the place they're working becomes a control group for a cluster randomized design or for a traditional design. This is an option that allows everybody to get the intervention. In the end, everybody gets the intervention. But remember, this is very different than a traditional clinical. Units of randomization are intact groups. Intact groups, clusters, meaning they're intact. They're not changing. If you have a school, Armando de Moraes, that's a school, right? It's not changing. And within the school, there are students. So these are units, individual units within individual clusters. I'm randomized on clusters. If I have an intervention, let's say a health literacy and health promotion intervention around obesity for children aged 10 to 14. Okay, if I have that intervention and I have 100 schools in a public district, and I gave 50, I randomized into clusters, 50 for treatment, 50 for control. I have a cluster randomized design. I randomly sample the treatment clusters and randomly sample the control cluster. Now, if I implement this in a way that everybody starts as controls, and over time, little by little, every cluster becomes a treatment I randomize on time. I'm going to show you how that's done. We still are in a cluster randomized design, but now you have a stepwise, and you randomize, it's a still randomized design. Classes receive the intervention at different points in times, like I said, because we randomize it to different points in time. Let's say I have cluster 1 to 100, and I have 1 to 50, and 50 to 100. So I randomly sample cluster 7 and cluster 33 by chance to become treatment after 6 months. And then after another 6 months, I end up with 2 other. And this randomization is going over for 5 years. I end up randomized all schools into treatment and control group over time, based on time. Okay, we're gonna show that in more detail. I'll show visual diagram, and you can see that. Data are collected from each cluster over time, but the way we do is through periods. I'm gonna show it to you. We do every time you move controls into treatment, clusters into treatment group, all of them are control emission into treatment. At that point in time, you do a measurement. You measure everybody who's still control and the new treatment, you measure them again. Multiple observation from the same clusters will positively correlate. That's a fact, because you're gonna have multiple measurement on the same individuals within the cluster. That's called cohort stepwise cluster design as a cohort. I'll show it to you that later on. The interclass correlation is there. Remember that? ICC needs to be estimated for both sample size calculation and analytical work. Here are some terminology on the stepwise design. So you have your sequence, row-wise, sequence 1, 2 through 4 in this example here. You have 8 clusters, 2 in each sequence. And then after an initial period, which I call a transition period, that everybody is in control, okay? I do a measurement. At that point, that's a baseline measurement. That's the arrow going up. That's a measurement. So I do a measurement, and after that, from the transition from the first to the second period, I randomly allocate 2 of the clusters to intervention. Not necessarily you want to do. I'm showing you 1 and 2 is just diagrammatically to show you how sequentially we are allocating. But if I had randomly sample from 1 through 8, it could have been 8 or 7 that had gone to become, the so-called intervention group. So in the first period, 2 clusters become intervention. On the third period, 2 more clusters become intervention. On the fourth period, 2 more clusters become intervention. And on the fifth period, 2 more clusters become intervention. Therefore, by the end, and the period number 5, I have all 8 clusters are receiving the intervention. You follow that? And I can do another measurement if I need to, between 5 and 6. I call 6, period 6, another transition period in which I analyze everything. So I may end up with 1, 2, 3, 4, 5 measurement. So every time I transition from each one period to one. So let's say you have so there are 5 periods here, right? So let's say you have 2.5 years. 2.5 years to implement and to evaluate this intervention. So you say, okay, every 6 months, it's a period for me. First 6 months, I do my baseline assessment. Exactly at the end of those 6 months, I allow them to be observed by me for 6 months when nothing happened. By the end of 6 months, like say, month 5th, I'm starting January, so February, March, April, May. In May, I do measurements. Boom. Finish by June 1st. Boom, finished. Did a full measurement. Everybody's getting the same measurement. I'm interested in, let's say it's an intervention in a clinic, and the outcome is, glucose level. Okay? Let's say A1C. My outcome is A1C. Are you familiar with hemoglobin? Glycated hemoglobin, A1C. So I measure A1C in everybody, and I also measure a bunch of other factors who may confound, who are affected, and I know that all of them are controlled. So everybody here, it's a control. Okay? By period 2, I allocate 2 more in the second period, 2 more clusters to the intervention group, and then after I do that, it takes me, 5 or 6 months of intervention. I measure again. Now already, these people are having 6 months of intervention. There's 2 clusters here. I don't know how many people are there. And the cluster in this example here are clinics. Okay, my hospital system has 14 clinics in Columbia, Missouri. So let's say I allocated 7 to a very intensive glucose monitoring and aggressive insulin giving for patients who are type 2 severe diabetes or type 1 diabetic person. So I do a very aggressive monitoring every 4 hours, monitor glucose level and intensive aggressive regime of insulin. I just made it up. Okay, and the other group is getting the traditional. Allow the patient to measure whenever you feel like, given the orientation usually is 3 times a day before, in between meals, and then before going to bed, and taking insulin as needed. So I observed these 2 groups. So everybody was in the status quo standard group at the beginning. After period 2, 2 more clusters, 2 more clinics are beginning to intervene with this aggressive glucose control strategy, and so on and so forth. So you end up with this similar design that you see here, steps. So each period can also be called, going from one place to another is called a step. Step is the time in which the intervention is implemented, and the duration between step is the step length. So from period 1 to period 2, this line here, that's a step. It's almost like going on a step on the stairs, or one step in the stairs, okay? And so on and so forth. Besides baseline measure, the follow-up measure taken immediately after intervention is implemented, because then I'll obtain information before the intervention, and then the next time I have information about before the next level of intervention, but also in the preceding period for the intervention. So here's a little bit more detail on the step wedge, but here I allow for transition period in between. It's the same design we had before, but I say, well, period 2 is going to be a transition, a whole period, and then I give another period 3 will be a transition. So period 2 is going to be a transition for everybody, okay? And then period 3 is going to be a transition for some of the other clusters, and so on and so forth. You can do something like that. But ideally, you should shorten the transition time to be very little, just to allow for operation, administration, and time. Because if you just put, like we had here, so assuming that exactly in 1 day or 2 or 3 days everything is done, it may take weeks, right? So you allow those weeks to be in between. Another example of a complete step to wedge designs, another way to look at is with 0, 1, 2, 3, and 4, 5. You can see that, right? So you can see all clusters are measured every time point, regardless of when they receive the intervention. Although the intervention is not implemented until period 5, for all the clusters that appear in block 5, outcomes and predictors are still measured at all preceding points in time. So you're still doing the measure every time you have a step. Step to the line dividing each time period. But you can end up with something like that, because real life. So here, everybody gets, you see that, the 0, 0, 0, that's your control, that's your intervention, is 1, 1, 1. And 0 to 5 are the period. Remember the 0 to 5 is the periods, okay? So everybody gets the intervention, some don't, okay? But in real life, you end up with something like that. Not going to detail too much, but it could happen. But at least you're going to have some zeros and some ones to compare. Remember, if I'm doing analytical work now on the randomized trials, in the randomized cluster trial, I have a variable that defines treatment control. I have an X variable, okay? That variable say if it's 1, if intervention, 0, if it's control, right? So when I put that in my analytical programming sets, data, R, whatever, it allocates. So you still have some contrast between those who have the intervention, those who don't. It just lose information. So this type of analysis lacks power, because even though I had allocated enough clusters, I end up with very little clusters. The point means I'm missing values here. It's possible, right? A little bit or more on that, you can see how the cluster, the step wedge cluster comes through time with some other language. Just for you to be familiar with the language. Duration of trial is the letter A, is the time arrow on the top, the very top of this diagram. The crossover points, which are the steps, remember that I call also steps, then it's the B, you see that? C is the second step, so B is a crossover point, but that specific point on a sequence, the second sequence coming from the clusters on the top, the cluster at the bottom, that's also called second step. The next one is the third step, and so on. Number of cluster, D is the number of cluster in the second group. So who is D? So the second group here, the second sequence or group, okay? That's the D. I'm giving a little bit different terminology so you don't get confused. you go to the first terminology I gave you earlier, because different books, different papers use different terminology. I wanted to give you that flavor. Total number of clusters is given by F. As you can see here, the F is the summation from top down or bottom up of all the clusters. 1, 2, 3, 4, 5, 6, 7, 8 clusters in this example. And each 2 clusters are put together in a sequence, okay? Or, like I wrote here, D, a number of clusters in the second group. That's a sequence, the number of clusters in the sequence. E is your number of groups. So you have 1, 2, 3, 4 groups of 2 clusters each. So you have 8 clusters, okay? So that's your E. Your F is the total number of clusters. So you can count the number of clusters. I already showed it to you. Pre-rollout period, that's the G. That means I have not rolled the intervention into the groups. So it's pre-rollout period. Once they run the intervention to the group, that's a rollout period. Okay? So the G here is this period that everybody's controlling this period. So all the values of the outcomes, as well as the exposure variables, the treatment, everything here at this point, everybody's controlled. So your X variable for control is value 0 for everybody here at this point. In your data collection, if you collect at the first inflection point, the first line on the top sequence, there's a line, an imaginary timeline there. If you collect that data, everybody's going to have that X variable with a value 0. As you move along in time, because clusters are randomly allocated to time periods, okay? So remember, the randomization is on the time, it's a combination of cluster time. They are randomly assigned to periods. So the period is the random. The unit of randomization, the clusters allocated to period, okay? What else do we have? H. Time between second and third crossover points, that's H. Okay, as you can see that the first point, crossover point, is when I cross over from the first treatment sequence group to the second, and then the second crossover point is the next one. So that period is called H. It's just any period of crossover points. Okay, post rollout period is your I. Everybody has been treated. Now you have a G time, where everybody's controlled, and I have an I time when everybody is treated, okay? And then you have the rollout period is the whole J coming from the first treatment to the next, to the very last one, treatment group being allocated. So that's your stepwise design, and you can see that you can say the trial duration is the summation of G plus J plus I. G is the so-called pre-rollout period. I is the so-called post-rollout period, and J is the rollout period. So the whole duration is G plus J plus I. Total number of clusters F, as you see it on the left-hand side. The length of time between successive crossover points, step length. That means what's the size of each period should be the same and constant. That's your step length. Number of groups as E, as you remember. There are 4 groups here. Number of clusters D. Okay, so there are the clusters within group, it's your number of clusters per group is T. So you have 2 in the first group, 2 in the second, 2 in the third, and 2 in the fourth, so you have 8 clusters. So the the stepwise can also be divided into 2 types, major type. One is called cohort design, the other one is cross-sectional design. In a cohort design, you can read this over. You basically say, hey, I'll randomly allocate the clusters, let's say clinic, my 100 clinics, 50 allocated to treatment over time, and 50 initially, all 100 were controlled. Okay, that's my stepwise design. But within each cluster, I will measure everybody once and multiple times. Every crossover point, I do a measurement. And I measure everybody, this very same person, not very same person. So I need to recruit these people ahead of time. Even before I do the allocation to treatment and I'll keep them as control for 3 months, 6 months, or a year. I say clinics, you're going to be randomly allocated, or I can do the randomization of the clinics ahead of time or not, but I need to get to the patients earlier and say, hey, folks, you're all going to be part of a study. Please consent. I need to have the consent. So if I'm going to do, realistically, I have 14 clinics. I'm going to do a trial, which we did with 7 clinics in being treated over time, and then over time, another 7 become treated after second, third, and fourth period. So I'm doing step wedge. I need to get to all patients in this clinic, send a letter, and say, many of you are going to be involved in this study, and I'd like to recruit you. And if you accept to be in that study, it's going to benefit you, these are your benefits, blah, blah, blah. I would like for you to sign this consent. There will be no, if it is the designer described to you on good cost, I will only send that to diabetic patients, all the diabetic patients in the clinic. You see how we do this thing? You recruit them ahead of time. Because once they are in, you're going to have to measure the same individuals over time. Okay? And that's your cohort design. Remember, you can read all these details here in the interest of time because you had some technical problems. Start a little bit late. I will do. There's another type of rollout step wedge cluster randomized design, which is the repeated cross-sectional design, usually reserved for large public health intervention like the one I had in Missouri. Okay? So there are 150 counties, 150 local public health agencies. Okay, there's over, I think close to 1,000, no, 1,000 is too much, maybe, what's the average, I think it's 2.1, 400 little towns, villages, and cities in the whole state, okay? So let's say you want to do a large-scale intervention, and you want to do a rollout design, so whoever selects as clusters, the clusters a whole city. So I have enough large number of people. A smaller city would be like 500 people. The largest city would be like 3.5 million people. So I don't need to get everybody every time I do the measurement. I need to have a random sample of people in the city. They are correlated with each other. They have an intraclass within variance, and then I can estimate that actually. Okay, so that's different. So that's what the repeated cross-sectional step wedge rollout design is. You follow that, folks? So compared to the one in clinics in which I select the clusters, and within clusters there are patients, and the patients who are fit, my eligibility case definition of a case to be in this clusters randomized study over time, then I involve them all, and I'm trying to select those who say yes and consent. They are the cohort that I'm going to follow up over time within clusters. The same individuals measure over time. Okay? Whereas here, I have large number of people, lots of people. I don't need to follow up each individual. It's going to be almost impossible, actually, it's infeasible. So I will random sample within that city. That's my cluster. So I randomly sample the cluster, and within the city, I sample again. I do a cross-sectional design. Okay? You follow that? The difference? Clinics, typical example of a cohort, step wedge, randomized controlled trial, cohort type. Clinics, patients in the clinic, they are the same patients that we measure over time. Okay? Whereas here, I have people in the community, and I randomly select the cluster, so I randomly allocate clusters to treatment over time. But within the cluster, I randomly sample adults to be in my study, usually for large-scale interventions. Let's say a screening program for cardiovascular disease. I want to test if cholesterol screening is effective in preventing sudden coronary death. Fair question. So I design a step wedge, a cluster randomized trial, and then I do through a repeated cross-section implementation through a cross-sectional design. Okay, so it's a combination of the step wedge randomized cluster trial with a cross-sectional overtime design. You follow that? As the trial begins, very few individuals participate. Over time, more become eligible and they exposed to intervention for a short time, after which the outcome measures typically measured. Read over, but the more important thing for me is for you to understand the difference between that and the cohort. The cluster randomized design has some challenges, especially with regard to sample size calculation. So like I said, the easier and the technical right way to do it is that you define your sample size a priori based on a simple view of the randomized clinical trial. Instead of a cluster, think about randomized clinical trial. Then you multiply by a factor called design effect, and you remember the formula I gave it to you. Okay? So standard feature, number of cluster, cluster size matter, because in that design effect, you're going to see the number of cluster and the cluster size, N and K. Okay? Stepwise cluster randomized trial, same feature of the cluster randomized trial, like clusters and sample size, and cluster size to estimate sample size calculation. But added feature of the number of crossover points, the number of cluster switching intervention arm at each crossover point, possible time and lag effect, whether the data collected for in a cross-sectional manner or cohort, which is repeated measurement on the same individual. Package for implementing this calculation for complete design. I had a slide, I believe I put in slides 27, but if I didn't, I'll send it to you. I think I'm being too unrealistic here. Not all packages have that, but SES does that, and I'll give it the reference to you. Okay? So remember, to calculate the sample size for a simple random sample is very simple. To calculate the sample size for a clinical randomized design, I gave it to you last week. I gave the formulas. Okay? So what you do here, you have the same feature of the simple clinical trial randomized design, and then you add the feature of the cluster randomized design, get your sample size calculation, then multiply by these factors, which are typical of the cluster random sample, especially the crossover point, the number of clusters switching, possible time and lag effect. So remember, simple random sample is very simple, calculate sample size calculation to estimate a prevalence, for instance. Then the high level of computation is the randomized clinical design that has a lot of stuff in the form, including the expectation of the impact, of the effect of your intervention. So that's your individual level randomized clinical design. So you calculate that like if you're doing a clinical randomized design. Then you add the feature of the cluster, number of clusters, cluster size, to the formula of the sample size. And then you have also take care of number of crossover, that's for the step wedge. Number of crossover point, number of clusters switching intervention, each crossover point, possible time or lag effect, that's a kind of factor variance, okay? That's a bias by time, which you take care usually by adding a time component in the analysis as an independent variable, independent random fixed effect for time, and a random effect of the duplication of time and intervention. Whether the data collected for step wedge in a cross-sectional manner or repeated also matter, because the repeated, meaning the cohort, we have also correlation added by the repeated measure. That's a factor variance to management too. Package for implemented, like I said, I'll give it to you. It's called SWCRT design for complete design. Should be in slide 27. If not, I'll send it to you. Simple size notes, you can read this. What time is it, Rafael? I've got you. Gabriel. No, Rafael. Gabriel, what time is it? My watch is good. 10:20. Okay, we started at 9:30, but we'll 10:15 minutes. So I have another 10-15 minutes. Bear with me. We'll finish and we'll go over for a little break. So I'll read over on sample size. Let's get to at least power by design variation. This is an important concept. As you remember, you can do a priori calculation of power. How much power my analysis will have given that sample size, given that expected effect of the intervention on the outcome. That's an important concept. So I'm giving to you a little bit how this intercluster correlation affects that power calculation. I give you the factors here: simple parallel cluster randomized design, a parallel trial with baseline period, a step wedge trial for both two levels of intracluster correlation, the whole 0.01, which is very small, and a little bit larger, way larger, 10 times larger, 0.1 row. And so you can see that for the different design. Remember, the first two are cluster randomized design only. The last one, the third one, column, the fourth column, is a step wedge cluster randomized design. Okay, so number of clusters the same. On the first group here, interclass correlation coefficient of 0.01. Cluster size is the same, 50, 20, and 50. Total sample size the same. Number of steps, yeah, cluster, there's no step. The parallel, we have a baseline, and then you can do another measure. But in a traditional step wedge, you usually have 4, 5, 6, but at least 4 measured number of steps, right? Number of cluster per steps, look at the number of clusters. I can have 10 in a traditional parallel trial. I have 5 in a step wedge, which is an advantage of step wedge too. I forgot to mention that. So the power calculation comes about like that. Traditional cluster, single parallel trial will have 0.97, huge power. As you do a traditional randomized trial, you have 0.97. A cluster randomized design, we got 0.87. And then in step wedge, you got 0.88. So they lose power because of the interclass coefficient. Now, look at the effect when the interclass correlation coefficient is very large. It's a tremendous effect, but it's not because you take into consideration the interclass correlation coefficient. If you do a simple parallel trial, you actually have less power because you're actually making a lot of type 1 error because you're not accommodating the two sources of variance. This is, by the way, this is assuming you're doing the right thing in the analysis, okay? Whereas a parallel trial, you get 0.77. The step wedge, it's advantageous, actually, because you do a better job in assimilating this between and within cluster variation. So in the analysis, you need to pay attention to in a parallel which available cluster observer and control, distribution result across an exposed observation period compared to that across the exposed. This means that both within and between can be used to estimate the intervention factor. Whereas in a real cluster, you're only doing overall, like assuming a homogeneous general effect in a random cluster design. Whereas in the step wedge, you actually use, maybe I'll have a chance to show, I don't know if I remember well, this Henry's paper actually gives a lot of details in how you should go about the variance estimation for this cluster design, what type of random effects model you need to use. But that means if you do the right analysis, the step wedge actually gives an advantage. It estimates the variance more precisely, more importantly, the best statistic would be more appropriate. You're not going to be evaluating type 1 error, type 1 loop. Like classic parallel, step wedge must take into account various level of correlation. Like I said. What else do I say about the analysis? Take the place of R. Step wedge, yes. Exposed and exposed observation periods, not people, but periods, take the place of arms, treatment control group in the trial. Thus, the distribution result across unexposed observation periods compared to that across the exposed observation periods. Highly comparable. And with any randomized comparison, the individuals in clusters should be summarized by the exposure status so as to allow consideration of selection bias and lack of balance. You can estimate that later on a posteriori. Where there are a small number of steps, these can actually be compared by the randomization group. You can always test very simply at the end of 1 year if your randomization provided clusters which are similar on average. So I have 24 clinics, 12 and 12 at the end of 1 year, I should be able to look at this and say, you know, it's very, this clinic is very large, this is small, but I randomized so well that I end up with the same number of large and small clinics in each group over time. I should, because everybody's going to get the intervention, right? Number of new recruits in each cluster period, number for whom data were available. This is an example of study site presentation that could be applied to a cross-sectional step wedge cluster randomized trial. So here, the numbers are not exactly the same. intervention condition period, control condition period. You can see that with colors, okay? And this is how number of new recruits, number of new data available. That means you have loss, but it's kind of a, so example, period 1, I have 50 people who are in a control group, but only 45 allow me the measurements that I need on that person. So I lost 5 people there that I don't have any information. Likewise, the next group, next cluster, I have 60 people, only 55 give me data. Another one is 3, I have 98 people, only 92 give me information. So there's this number of whom data are available. There's loss, but if you look across, you're going to see loss are very similar across groups. Because the person, let's say this group, the cluster and the first group, I'm talking about cities. Instead of 60, I had 600. Instead of 50, I have 500. Like large intervention trial. Okay? So this sequence, cluster number 2, that becomes a sequence by itself in this design diagram that I'm showing to you. These 60 people here are the same cluster, right? That are on the second period, 56 people, 52, 98, and 67. So they are the same people, so that they tend to behave similarly. So the loss to measure, loss to follow up is very similar percentually over time for the same groups. And across groups, they're not too different. Okay? So another thing to pay attention in doing the analysis, this is the most important thing to you. Think about, you can read over, I'm not going to read it like I read some of the other slides. Time. In a crossover design, that's better example. In a traditional parallel design, simple, randomized clinical trials, I don't have the issue of time at all. The cluster design, traditional cluster, neither. I don't have the issue of time. Stepwise, time is a very, very important variable. Remember, I randomize cluster on time periods. So it's almost like I'm randomizing in time. Okay, so think about it. The people who are in a, I have, let's take this example here. We're back here. Here. So I say time 0, 1, 2, 3, and 5. Okay. So I have blocks of clusters. Maybe each sequence here, each row is a sequence or blocks of clusters. Okay. It's one cluster, each one, to simplify. Okay. But it could be 2 or 3 in each one. So these people here, they're going to get the intervention like that. They're on the top. So at the first inflection point here, the first vertical line, on the left of the letter B, left of letter B, the first line. At that point in time, okay, 2 clusters obtain the intervention, receive the intervention. Evidently, these top 2 clusters are going to have longer exposure to intervention than the one in the very last 2 clusters at the bottom. See the last 2 clusters? Let's say this is about 2 years. So this last 2 here are only getting 4 months of intervention, whereas this guy here had nearly a year and a half. So you would expect that the effect of the intervention to be strong in that group. You could analyze like that. If you do that, you may adjust, but it's very complicated. But the more important thing is time is an important variable. It affects the total effect of the intervention. You with me? Also, the people within the clusters, they are correlated, but they also correlated in time. They also correlated in time. And some things cook up inside you biologically over time. The other important feature is the secular trends. What is secular trends? Something was going to happen anyway. But you're just taking a window in your study design, a window of time to do your study. Even if it's nearly perfect, you still have secular trend doing something there. Maybe it's a behavior, maybe it's an economic, maybe it's a social thing. That's a phenomenon that happened in the entire region, the entire country, that's affecting something that affects health. Well, that's time. And those who have longer, will have more of the effect of that cyclotron than those who are shorter. That's a different type of effect. So time is an important variable that you need to take care in the analysis, always, okay? So I hope I'll get to the point where you are smaller, we discuss it, minimize. So, for example, the outcome measure in a stepwise rollout of vaccine intervention could be affected by seasonal variation in infection rates. As you remember, if you talk about infectious disease, talk about mosquitoes, let's say I'm a receiver where I'm coming from. It's an infirm. It's the devil's advocate, I would say, the mosquitoes there are really insane between April and August. Okay, come to the peak of the summer, 3 weeks no rain, mosquitoes are gone. Okay, so it's seasonal, right? So I expect more infection, more dengue, more chikungunya, more Zika virus. A few weeks after the rainy season starts, and it keeps going until August, September. Okay, so that's seasonal. If I'm doing a trial, I'm trying to understand, so this is different, it's about hepatitis, but it's also seasonal. If I'm doing something to intervention on chronic disease prevention, around nutrition, around, okay, my intervention is to have, over time, in 5 years, people eating more fruits and vegetables, healthy. It's unanimous, everybody accept that. Doesn't mean it's the only thing that I do to make health, but it helps, right? But I'm doing my research in Minnesota. For 6 months in a year, they have to import fruits from the other states or other countries. So the price of fruit goes high, and there's a lot of demand because the demand is the same, but the scarcity of the product makes the price goes up. So not everybody's going to get fruit and vegetables. So it's a seasonal effect on my consumption of fruit and vegetables. Nothing to do with the intervention. You follow that? So time affects everything. Also, like I said, because the way it's rolled out, on average, for earlier on to later time, some people have a longer exposure. So time is a potential confounder. You should always have time in the model. And depending how you assume the variance to be, because I mentioned to you this within and between variance, right? But there's a little bit more than that. I can model the within variance in such a way that time is inserted in that variance estimation. Let's say the within variance, or the effect, which is a reflect by the within variance, the effect of the intervention is decaying over time. The intervention is losing effect over time. And that you should expect because of tiredness, lack of compliance, lack of standardization. You know, remember the difference between efficacy and effectiveness. Over time, there's a decay. If I put that into the calculation of my estimations, that's a different analytical work. Okay, so I have two options here. Just incorporate the between and within variance in the analysis, which is already excellent compared to not. But I still can also incorporate the time issue, the decay of the effect on time. And there are two ways to do that. I'm not going to get into that too math. Even I have to read again, slide over. I'm not a statistician. I'm just a methodologist who's crazy about statistics. I know how to do my thing. I want to be responsible for not estimating a variance for somebody else. But you can get to that nose paper I gave it to you. You gave me that detail. So you already taking time into consideration the analysis by adding a fixed effect, okay, time in your regression models. Remember that, fixed effect. In addition, you're going to have a random effect, a random intercept. So you have your traditional intercept, you have a fixed effect for the treatment, you have a bunch of fixed effect from potential confound, you have a fixed effect for time, and you have a random intercept variation. So that random intercept has incorporated time into it. I'm not going to get into that, but it's very important to know that. So going back to this issue of potential confounder, you know how to take care of confounder, database confounder. I think, and that's through analysis by adding the confounder as an estimator, a predictor, or a potential confounding variable in your models. The models in SAS that when I use, it's a mixed effect, a mixed model generalized mixed model GMM insects. Okay, so I think it's Prof mix will do that insects. Okay, so ask me later on. I'll try to send you a few things about that. I'll give you finally a little example here. This is a schematic diagram of a drinking water issue in Bangladesh, where they had problem with salinity of the water, and they have to manage the aquifer to recharge initiative to reduce drinking water salinity. So they designed an engineering process using rooftop collecting rainwater and then diluting and cleaning the quality of water, which is brackish groundwater, to become drinkable and reusable. So that's the intervention. And these are the region of the intervention. I'm going to go quickly on that. So how do they design the intervention? So you can see from 16th December through 17th of April, it's very short period of time. Step 1, which is the first period. Step 2 coincides with the second period, and so on and so forth. So in each period, they had altogether 16 towns or villages, all controlled, they are blue, right? And then over time, I introduced this intervention, this desalinization process into the first village, 4 village, and then the next 4 village, that's 8, the next 12, the next 16. The outcome of interest, if I'm not mistaken, was, forgot, health effect, cardiovascular health effect, because they thought the salt in the water may increase blood pressure. So they're really looking to blood pressure. So that's your design on the top, okay? Number of participants in each study, these are the number of actual people in each one. So altogether, there are 900 people in those 16 clusters, 16 villages. You see that? So over time, everybody gets the intervention, okay? It becomes orange when they work, blue. You see that? That's a real, and you can read the paper, I put the thing here. So I wanted to see, this is very simple concept, highly ethical, highly feasible to implement, and this is the best still experimental or randomized control type of trials that you can do in real life, clinic, health systems, school systems, more importantly, cities, towns, regions, suburbs, biomes, right? You can do that intervention in large scale and use this randomized design. Thank you, folks. I'll take a 10 minutes break. We start with the next topic, which is not a completely different design. Okay, we're going to talk about natural experiments in general, and we extend that over with another lecture on time series, interrupted time series, and then tomorrow we do 2 more of these non kind of randomized type of intervention.
o laboratório todo automatizado, com robôs, fazendo a produção manual.
Testando, testando, dois. Tá ouvindo agora? Dois, testando.
Teste, teste, som testando.
Publicado no Jamba, não sei o que e tal, e no mundo inteiro é um salto muito grande. Comparado com o que da América, com o que hoje já tem. Mas Welcome back. Sorry, I was speaking to mute microphone. So now you have had. Can I speak? What's going on here? O que é que está acontecendo, Gabriel? Including the most important one that I think is important for Brazil and many places in the world, which is step wedge plus the randomized design, which allows you. Where's the lecture? Gabriel, onde é que está a aula?
Pode tirar aí, dois, coloca na aula.
Onde é que está? Onde é que está? Where's the lecture? Gabriel, onde é que está a aula?
Pode tirar aí, dois, coloca na aula.
Onde é que está? Onde é que está? Where's the lecture? Gabriel, onde é que está?
Fecha lá tudo isso. Fecha aqui lá.
Teste. Testando. Teste. Som. Testando. Teste. Testando. Testando. Teste. Som. Testando. Teste. Será que não é porque
Você tá ouvindo aqui?
teste, som, testando. Teste. Será que não é porque
Nem coloca.
agora? Tá tudo bem agora? YouTube? Tudo bem? Pronto. Oxe, mas tá repetindo. Ó. Mas aqui tá repetindo. Não tá? Teste. Testando. Ó. Tá vendo? Deixa eu ver.
Dispara o microfone daqui. Dispara o microfone daqui.
Não, aí é a câmera.
Não, você tinha que deixar só.
Iniciei. Aí, ô, Guilherme. Teste. Som, testando. Teste.
Cinco segundos depois vem relógio.
Testando. Teste. Testando. Sabe o que você faz? Calma.
Tecnicalidade.
Testando. Teste. Testando. Teste. Som. Teste. Tá tudo certo, né? Agora não tá.
Sorry for this technical problem. We're going to review natural experiment, which does not include stepwise cluster randomized design or traditional randomized trial. It includes other types of designs, and it could include a cohort study, for instance, or case control. In the very last day, I hope to give you some unusual examples here of unusual applications of observational designs that I had to do it in adaptation to reality. So we're going to skip that part because we are so late. It's really about evaluation as a whole. Read it. It's basically about very key concepts of why we evaluate, what is evaluation, and so on and so forth. Okay. Guilherme, can you? Okay. Sorry there was another technical issue here. Remember, in everything we're going to talk from now on, you need to remember about something called counterfactual. And counterfactual is a concept that basically say what would happen without that information, without that program. So I need to have a measurement of that, or an estimation of that, or a reality of that. Okay. So because the estimated impact or effect that you're trying to measure for a treatment effect on the outcome or an intervention on a health outcome, the difference between treated observation and counterfactual. You don't usually have now in a traditional non-experimental design, you don't have a true control group, a randomized control group. So you need to rely on the counterfactual many times. Never observe same individual with and without program at the same point in time. You're going to see that in the interrupted time series. You're going to see that into a regression discontinuity and the difference methods, which I'm going to cover one or two today and one or two tomorrow for you. Okay. So you need to estimate the counterfactual. Counterfactual is key to impact evaluation. So counterfactual, remember again, is what would have happened to this population in terms of this outcome. Let's say eating 5 or more servings of fruits and vegetables a day, I designed an intervention in 15 cities in the state of Missouri to increase the intake of fruits and vegetables from the average, which was 1.5 over there, to about 5 a day. And then I use other communities as measurement of the counterfactual, okay, using large-scale population-based surveys of the whole state. So the whole state becomes the comparison, except those counties which eliminate them from the whole state measurement. So in that way, I'm creating a counterfactual, but it's not a true control group. The control group is only perfect when it's randomly allocated to treatment and control. And you have that in the individual level, randomized clinical trial, randomized intervention design, or a cluster randomized design of the various types. All of them have that feature. Here I don't. That's why we are in a quasi-experiment environment or universe. So you have the treated and counterfactual. You expect them to have identical characteristics except for benefiting from the intervention. So in this example I gave you, an intervention and working through the healthcare service and the public health service of those counties or cities in the state of Missouri. We wanted to increase the uptake of fruits and vegetables, the intake of fruits and vegetables, from 1.5 to 5 a day, okay, over a 2-year period. So we designed a quasi-experimental design. The benefit is eating more fruits and vegetables should improve your health overall. No other reason for difference in outcomes to treating counterfactual. So we expect that by the design, I would see no other reason to explain the difference. So I try to adjust for confounding here too. Only reason for the different outcome is due to the intervention. That's what you expect. So you have situation where you only have before and after. Same individuals measure before and after treatment. You can see change over time, but you don't have the counterfactual there. Those not enrolled, maybe those who choose not to enroll in the program, those were not offered the program may be completely different than the other ones. So in that way, you don't know, cannot completely know why they're treated, are treated and the others not. That's an issue in itself. I give some crazy examples here. I worked many years with the World Bank, and there are some examples there from agricultural assistance program, which does affect health, and that's why I put the example here. This is a good one. It has everything. The assistance program, agricultural assistance, financial assistance to purchase seeds and everything else. So you compare your outcomes, compare rice yield before and after this financial system intervention. And before is normal rainfall, but after is drought. But then you have the issue of rainfall and drought. Remember the time issue I mentioned to you? Fine fall in rice yield. Did the program fail? So the rice yield went down instead of going up. Did the program fail? Could not separate the identify effect of the financial assistance program from the effect of rainfall. And the reason for that, it was a before after. I did not have counterfactual to allow me to look into that. Same thing with a school education program or scholarships. Example one, job training program, comparing employment earning of those who sign up to those who did not. Who signs up? Those who are more likely to benefit. Those with more ability would have higher earning than non-participant without job training anyway. So once you do not have a good estimate of the counterfactor, you don't know what you're getting. I'm giving an example of lack of a good counterfactor, no counterfactor at all. Health insurance offer, and you want to compare healthcare utilization for those who have health insurance, those who don't. Okay, who buys? But then you ask the question, who buys health insurance? This is pre and post. Those that expect large medical expenditure, who does not? Those who are healthy. So if you're going to evaluate just pre and post, you may end up with no effect or reverse effect because you have a poor estimate of counterfactor and so on. So I can give you examples and examples. So we need to know all the reason why someone gets into the intervention or not when you're doing quasi-experiments, all the reason why individuals are in the treatment versus control. If the reasons they are in the program correlate with your outcome, like I gave the example before, then you bias the whole result. It's a selection bias. You may treat it as a confounder, but it's actually a selection bias. You selected people in such a way, but they self-select into intervention, and they have a reason for self-selecting. They are healthier. Okay, they self-select out of your intervention because they're healthy. They don't want your health insurance that's a low cost. Whereas those who want the health insurance, those who are worried about their health and say it's more cost effective to have a health insurance. So knowing why they're getting, and if that why is related to the outcome, then you bias the whole thing. It's called selection bias. Possible solutions need to guarantee comparability of treatment control, but now I'm not in a randomized territory anymore. Remember, randomization renders treatment control groups, either individual level or cluster level randomization, render the two groups comparable to everything except the intervention, except the treatment. Here, I don't have the luxury. So I need to find a way to create a counterfactual. Only remaining difference in intervention. In this seminar, we will consider experimental and quasi-experimental. We already covered experimental. Now let's talk about quasi-experimental. Before we go there, impact of follow-up designs, I'm going to give you this kind of listing of things. So we're talking about natural experiments right now. Interrupted time series, a type of natural experiment, difference in difference, as well as a cohort study. I did not list it there, but observational designs usually are a form of natural experiment. Before and after, it's kind of a natural experiment of the lower order. Enroll and not enroll, it's the same as before, after. Step wedge, it's not, but I could conceptualize the step wedge I gave it to you this morning is a randomized step wedge cluster design. It's different. But I can do a step wedge quasi-randomized design. No randomization, but still deliver the intervention as step wedge. That's how I was going to do in Missouri in that example of fruits and vegetables. Regression discontinuity design, we're going to see that tomorrow, is one type of non-randomized design. Matching methods, the randomized controlled trials, they are the ultimate way of evaluating impact, but they're not natural experiments, okay? Or quasi-experiments, so to speak. Here, I remind you again, the kind of diagrams, you can ask the question, can I assign exposure? If you do, yes, I can assign the exposure. Assign groups to treatment and control, then I'm in territory of experiment. If I don't, I'm in your observational designs, okay? But if I randomize the exposure, then I'm also in the territory of trials or experiments, but randomized experiment, that's yes. So yes to assign exposure, yes to randomization. I'm an experimental traditional design, and all these I cover for you: randomized control trial, cluster randomized trials, and stepwise design. Next, tomorrow is Wednesday? Wednesday. I'll probably cover something else, but on Thursday, I will cover adaptive design, hybrid designs. It's usually used for implementation type of research, effectiveness in dissemination trials. So you now have the option, yes or no, for randomization. If you say no, that's what we're talking today and tomorrow. It's a quasi-experimental, which is kind of the natural experiment as a way of using quasi-experiment or observational studies to take advantage of things already happening, okay? So I'll give examples on Thursday or Friday of that, and I'll give you 4 examples of that, and you're gonna say, oh, that's how you did it. I'm doing my own example, so you don't see from books. Control before and after study, you can do that. That's the lowest level of quasi-experiment. Interrupted time series, going to see that later today. Regression discontinuity and difference in difference, which I should have added here. We're going to see it tomorrow. Okay? So let's go. I will skip that. Recall, why is randomization, key elements, natural experiment. So in a natural experiment, you have if some context, direct manipulation, expensive, unpractical, and ethical, you take advantage of what's happening. For instance, in the state of Pernambuco, northeast of Brazil, about 9 years ago, we identified that the state agency, actually the whole government, made a decision to expand an intervention developed by the city of Recife 20 years ago. So they wanted to develop that intervention in a slightly different fashion, but still the original same intervention, but slightly modified to get to every city in the state of Pernambuco. But the manner in which they delivered that program in 5 years mimic a stepwise design. Okay, and that's why I'm going to show it to you on Friday. So they're doing that. I didn't do it. I did not manipulate. I did not allocate exposure. Remember that graph I gave you before? I can allocate as experiment, but sometimes even if when I don't allocate the treatment, even if I don't allocate my randomization, but somebody's doing it on my behalf, like the government of Pernambuco, I take advantage of that. That's a natural experiment. You see the difference between the word quasi-experiment and natural experiment? I would treat it as a quasi-experiment, but somebody else did it. I did not manipulate. Okay? So natural experiment usually are quasi-experiments and observational design. Quasi-experiments are interrupted time series, difference in difference, the so-called regression discontinuity, and some form of step wedge or cluster trial that there's no randomization, but somebody else manipulated the intervention. That is a natural experiment. On the other hand, I can also use case control and cohort as natural experiments. Okay? So natural experiment means I don't do it. Somebody else did it. I'm taking advantage. I'm observing. In the observational design, I'm observing individuals taking up smoking. That's Sir Darwin Hill's study on lung cancer and smoking, cardiovascular disease and smoking in the 50s. Okay? If it's a whole country, whole government, a whole agency, a whole private sector industry which is doing something and I'm observing that, then it's a quasi-experimental approach that I take it. That's also a natural experiment. So you're beginning to see the difference between true experiments involve manipulation of the exposure, randomization of exposures. Okay? The non-true experiment, meaning quasi-experiment, involve manipulation of exposure but not randomized. Observational design involve observing events are happening to individuals. That's cohort study, case control, cross-section. Okay? The natural experiment is taking advantage of the observational situation and quasi-experimental situation in which I did not manipulate the exposure. That's called quasi-experiment within the umbrella of natural experiment. You with me? I hope you so. Best cohort design ever, the first one, but also an observational design and a natural experiment. This is happening. People are going crazy about cholera. And all he did is to observe where the cholera cases were occurring. And this is 1855, and John Snow is considered to be the inventor of modern epidemiology, or the father of modern epidemiology. And they have a nice pub in London, which is very old. That's called because he used to go to that place, and that's where the pump, the water was nearly situated nearby. It's called the John Snow pub in homage to him. And Dr. Ramos and I had many beers over that pub when we studied at London School of Hygiene and Tropical Medicine. So he had a hypothesis about cholera that was different than the prevailing hypothesis. The prevailing hypothesis, you catch cholera in the air, miasma, that's what we call. And he said, no, the numbers, I plotted geographically. So he was the first to do GIS, by the way. So he plotted the cases, and he noticed some agglutination of cases, cholera death, and the blue is water pump. And you notice that the absolute majority of very strong cases are around some water pump, especially in the middle. So I'm not gonna, you can read this over, it's a classic. He basically tallied the death from cholera, okay, and death in each of 10,000 houses. And you just put in a table the source of the water, rest of the limited company, Southwark Vauxhall. So he noticed that the water pumps are related to the cholera by looking at these numbers like that. He had a hunch based on a geographical view, and then he went to test it out with his simple table here. What do you see? Number of houses, 40,000, 26,000, 256,000. Death per color. Death per every 10,000 house. What you see is a gradient. You see huge number of cases per 10,000 houses. That's the rate. That's the incidence rate. Remember the calculation? Okay. So 315 for every 10,000 houses, where Lambeth Company only had 37. That's 10 times less. So the frequency of occurrence was much higher in one group than the other. And the occurrence over time was much faster too. Okay. So that's John Snow's. The other things you can look at, surveillance data of monthly fatalities in Illinois for seatbelt use. Here it's an observational design. John Snow, it's a cohort study, it's a classic cohort study. Maybe it's worth reading what I wrote here. I don't want to read now, take some time, but I want you to read that later on. Another natural experiment is just look at a RIMA model, which is a time series analysis regression of the occurrence of accident, death, and injury. Okay, and then you over time. So it's a time series type of analysis. You're gonna see that later today or tomorrow, depending how I finish this lecture. Luis, we had like 30 minutes of technical problem here. It was very difficult. So we lost 30 minutes, yeah. So seatbelt law was passed. At that point in time, you can see a line in the middle, and you can see the curves, see if it had any effect on the law or not. That's a form of observational type of design. So I'm giving you some examples of that you can read over. I want to go quickly over this. It's all about the same thing. They concluded, looking at all those numbers, that there was some relationship with the seatbelt. But I will bring it to you another example from a friend of mine, Dr. Scobero from CDC in 1992, when he did a very thorough time series analysis and proved beyond doubt that use of seatbelt use had reduced fatality due in accidents and traffic accidents by, gosh, tenfold, something huge. Okay. A little bit more about evaluation. We're gonna really finish this lecture today. I went too quickly just to say this is a natural experiment. Because of we lost 30 minutes, I don't want to hold you. I know you need time to take a quick break. We're going to take a quick break and then continue the last lecture today. Sorry for going fast on natural experiments in evaluation, but the technical issues did not allow us to go quicker. 10 minutes, no more than that. Okay. Yeah. Well, we start late today. We start at 9:30. Yeah, we start again at 11:30 and go all the way to 12:20, 12:30. Okay, folks? Thanks. So welcome back. So now we are in the quasi-experimental territory, right? Thinking about natural experiments as one way of doing quasi-experiment, but you also can allocate the treatment non-randomly, and it's also a quasi-experiment that you allocating that. If you don't allocate that quasi-experiment, it becomes a natural experiment because you're observing people allocating interventions to groups, okay? Or you treat it as a cohort. I mean, analytically, you could treat it as a cohort design. Here's another type of natural experiment. It's the interrupted time series, very much in use for evaluation of intervention effectiveness. Um, if one thing I want to take it, you take it from this course is that the previous lecture on stepwise design, study it, read it, look at the papers I gave it to you, and I'll send you also the SAS code or the source where you can find the SAS code to estimate sample size for stepwise cluster design as well as to do some analysis using a SAS macro or PROC. I think it's a procedure not GLM, generalized mix model. I think it's PROC mix in SAS. I'll send the sources so you can find it. That's a most important lecture for you. This is another important methods that we can use to evaluate public health interventions or interventions over time and health systems, whatever. Interrupted time series, you can see the source. A lot of that material is coming from that source. I gave it to you. So what should be clear after this lecture? When, what, and how, more or less. It's not a deep analysis, but and just to remind you again, there's a bunch of counterfactual. Remember the counterfactual? Once I don't have a true randomized control, like control and treatment group randomized, I'm observing things. I need to get the counterfactual. So in a pre and post, I can always estimate the effect pre and post. Okay, T1, T2, time 1, time 2, treatment. So post only meaning, there's something going on the intervention program, and then at some point in time, the program I measure, but I don't know when it's coming from. So I've seen studies like that published actually, pre and post with controls. So that's more like a quasi experiment in which you have the pre and post, like pre is baseline, then you measure later on one group, and then you measure baseline and measure later on in another group. So you have group A, group B, and the effect's going to be A minus B or B minus A, depending how we look at the outcome. Okay, so and you can apply to this methods difference in difference. We're going to see that tomorrow. It's another way of analyzing that data. And then on Thursday or Friday, I'll give an example that I did, the difference in difference to evaluate the embryonic intervention called Obamacare in the US. There was a pre-Obamacare in New England, including the states, the Massachusetts, and the other states in that right-hand upper corner of the United States. So we're going to show a difference in difference. We're going to show an example. That's one possibility. The other one is this one we're going to focus today, which is the interrupted time series. You get the time series, and then you get the program, and you get the difference over time. Is very similar to a pre and post at the beginning, but it's not 2 points. It's a series of points. But you have more density of data. You have data measured over time, and you can estimate a counterfactor. I'm going to show it to you. Tomorrow, we're going to look into regression discontinuity, which is some of the general idea about the interrupted time series. It's a kind of a form, the interrupt time series, but the way you allocate the observations that you want is based on a qualification. We're going to see that tomorrow. Interrupted time series can be used when we have data about outcome over time, like coming from typical public health surveillance system. I showed one example early on a RIMA, which is a time series regression analysis on measurement over time. Okay, it's coming from surveillance system. Example, infectious disease surveillance system in Brazil. In 1981, I was working as a physician already in a public health service in Recife, and I was tallying the frequency monthly, actually weekly, of infectious disease occurrence, especially reportable disease. Brazil has a very old, like the US,
reportable disease system engineered by the Minister of Health. In most states have a pretty decent way of going about that. Okay, so that's a time series because you have measurement count of all infectious disease cases happening in the city of Recife. Not so good for the state, but for the city, it's pretty good. Over time, every week, you could tally. So that number becomes a time series over time, right? If I look at 1 year, 2 years, you're going to see the change. We want to understand how and if the outcome change after an intervention. Let's say I have a whole program in Recife going on back in my time to um, to kill mosquitoes. I found a way to kill mosquitoes. The best and most significant way we never did is sanitation. Let's say a sanitation program start in a city of 1.5 million people. The metro area is about 3.5, but the city itself is 1.3, 1.4, something like that. So let's say we start sanitation. It would take 5 years to have sanitation for the remainder of the 80% of the city, because the city of Recife only 20% has water sanitation that is modern. And that was created by the Dutch about 250 years ago. So all the remainder of the city has no sanitation except it's called septic tanks. Okay, a fossa in Portuguese, septic tanks. So in many places have no septic tanks. You actually put your deject in the running water or in the creeks or the river or in the trash. So anyhow, so if you do a sanitation program, example, in the city of Recife, and it takes 1 year, 2 years, whatever, and then you know that is your time series of infectious disease should change as a function of that intervention over time. So that's a time interrupted series. We're going to show that example later on. Your data need to include observation before and after the intervention occur. So examples, I gave you some, you can read that. Model, the dependent variable in this model will sometimes be a population average. So it's going to be like an ecological. Remember that early on, I gave a design called correlation, ecological analysis, the very first day. Okay, there is a design epidemiological in which the unit of measurement is not an individual, it's the average for a city, for a suburb, for a county, for a country, for a state, for a province, whatever regionalization you have. Okay, so that's an average. So the dependent variable may be sometimes the average for the population, like GDP for a country, crime rate in a city, math score in a school. Unlike most other policy models that require lots of control, these models can generate valid inferences even though you don't have a perfect control, because you can estimate a counterfactual. Let's assume we have data on total consumption of tobacco in the US from time zero to 10 years later. And bear with me, this is a graph that I created. It may not be perfect, but at least gives an idea. Our observations are represented in a graph below. The line suggests an upward trend with state residents consuming more tobacco over time. So tobacco consumption in the y-axis and time is in the x-axis. And I only have, general time here, but you assume you have T0, T1, T2, T3, T4, up to T10, T20, okay? Yearly consumption of tobacco from T10, T0 to T10, or T20, if you want to prolong that. So you're going to see that there's a random variation from one point to another, and variation over time. The variation over time is going up on average over time. Now let's imagine the policymakers decide to introduce a new tax on tobacco. Okay, and it happens on time 10. And I continue measuring because this is a surveillance system. I do a population-based surveys. In Brazil, you have the Vigitel, okay, which your zero was involved in bringing here to Brazil. That's a long story. I'm not going to get into that. So Vigitel was initiated here and used by University of São Paulo, Carlos Monteiro, right? But the way to implement it as a public health surveillance system is from the behavior risk factor surveillance system from the Centers for Disease Control. We create small teams. I supervise those teams brought to Brazil to help Monteiro and the group to bring that to the Ministry of Health. So that is available. So every year you can measure month by month if you want it, or every 3 months, or every 6 months. If it's done in Brazil, if it's done in the US like it is in Brazil, I think the one in Brazil is a little different They do a point in time, maybe twice a year, maybe once a year. There in the United States, is every day. Every day we collect data on tobacco, physical activity, sexual life, name it. Be it 150 risk factors for chronic disease and other diseases, including infectious disease, from the population and random sample of the total population US in every state and every city in US every day. So you can do time series daily to estimate the prevalence every day. So you have that, you put an intervention on T10, you can see the intervention continue going up. I'm asking you this question, is the intervention between T0 and T10 influenced by policy intervention? No, we cannot because preceded. And that trend continue up in the same slope. The slope is the same. It has not changed. So the intervention did not have an effect. Now, if I only measure at T10 and measure later on at T15, I can show that my intervention was very effective. But it wasn't. So the T0 to T10 is your counterfactual. That's what you'd expect. That slope. Remember the regression line? Remember regression? Linear regression? Y plus B X, A plus BX. Remember? The intercept and the slope. B is the slope, beta is the slope. The slope is the unit of change in Y for every, is the change in Y for every unit of change in X. 1 unit of change in X. Okay? So let's say time is my regressor, and the outcome is tobacco prevalence over time. Okay, so I have a regression that has alpha plus beta X, and X is time. For every unit of change in time, from 1 year to the next year to the next year to the next year, I will have delta change in the prevalence of tobacco. So that slope, which is the derivative of the line, remember the derivative of the line? Okay, that slope is the same. It did not change after the intervention. Guess what? Politicians in my city back in my time, 30 years ago, I pointed to them, you can't do that. That's wrong. They almost fired me because the mayor was trying to measure only from here to here. That's what I'm saying. The policy is ineffective here in this example.
If we read like this, it might look effective.
If you start measuring only after time T10, let's say you measure only after T10, first time you measure. That's my baseline is T10. And my follow-up is T15. So I commit the policy, and after 6 months, the prevalence went up. Let's say this is the prevalence of non-smoking instead of prevalence of smoking. Okay? Prevalence of non-smoking. I show a difference over time here. Good questions. Because the outcome here is prevalence of consuming tobacco. Yeah. Yeah, but the intervention is no effect. But even, let's say I'm doing something else. That's a bad example. Let's say is the prevalence here, instead of being tobacco consumption, is the prevalence of former smoking. A person quit smoking. The prevalence of smoke quitting. Okay? If the prevalence quit quitting, if I measure only from T10 all the way to T20, I'm going to show an effect. Okay? I'm going to show that over time it went up. There's more people quitting smoking after my intervention, after my policy took place. When in fact it isn't true, in this line here, the secular trend, that means the equivalent line that should be looked at, counterfactor, is the preceding 10 months. You give me the slope, so there's no change after policy, neither going up or going down. It's going the same way it was going anyway. On the other hand, in this figure here, I have a policy time, same T10, but now I see a little different. I see the time right is interrupted. The time series I had before is interrupted, doesn't continue the same slope. It continues at a lower level, same slope though, but at a lower level. So something happened at that point. But the slope is still continue. Ideally, you should go down and stay down, right? But it's now going up. So all things could happen here. In this figure, the tax does not reduce tobacco consumption immediately, but it shifts the trend downward in the long term. That's a good demonstration of potential effect. Again, folks, I don't have a control group. Okay, remember? So my preceding 10 months, 0 to T10, is my counterfactual. That slope, the direction of that slope, in the last point in time, T10, is my counterfactual. So a combination of the prevalence at T10, time 10, and the slope of the prevalence over time in the preceding 10 months on my counterfactual. If I change either one or the other, if I change from the slope that was in T10 to a slope in T11 goes down, go negative now instead of going positive, that's a reflective of that change. And eventually, the whole value of prevalence will go down anyway. You follow that? This is still the example of consumption of tobacco. Okay, let's revisit again. In figure 1.2, the tax has no effect on tobacco consumption, neither increase or decrease or change the slope. It continues the secular trend we're supposed to have. And this one here, there is an interruption. That's why we call interrupted time series. You'd expect some effect, but the slopes, the secular trend, whatever is the force that's forcing people to smoke more over time, is still there. It just went down temporarily, but it continue up, and eventually over time, we're going to pick it up. We're going to be coming to the level it was before. Here's a little different. It looks like the policy had an effect. Not only the slope changed dramatically from a positive slope to a negative slope, but also the value will change over time, going down. The prevalence reach a peak at T10, time 10, and it's going down over time. It's much lower prevalence after a few months. Finally, I have a biggest effect possible. Not only I have immediate effect of the policy, the prevalence went down substantially, but kept going down over time. That's the ideal effect that you want from a policy intervention. So that's why interrupted time series are very good at evaluating long-term change in policies. So it's immediate and a sustained policy effect. This one here is just a sustained policy effect with no immediate change. This one is immediate policy effect, but no sustainment. And this one is both. I have a immediate policy effect and a sustainment of that effect of the policy over time. So that's a strong evidence in favor that the policy is having effect. And that's what my friend Escobedo found in the seatbelt use and fatalities following a car crash in the US. So interrupted time series enable us to investigate each effect, thereby understanding if the policy intervention has no effect, has only an immediate effect, has only a sustained long-term effect, or has both an immediate and sustained effect. I will bring this back again, folks. Do you know how many studies in Brazil have done this that I know? None. It is so simple. You have hundreds of studies, like thousands over the past many, many years of scientific literature in public health in the US. So, folks, do more of that. Your data is there. You have now Vigitel for 10 years. Okay, albeit the Vigitel is only measured once in a year. It's different than the BRFS in the US, which is every state we measure every day. So I can estimate the prevalence daily or weekly or monthly. So I have more data points. The more data point, the more belief you have and more density to analyze. You can see the random variation, and you can see over time it goes up. But that can be used also for hospital systems. If you're looking for change, let's say a dramatic change. I did that in a hospital for infectious disease control. We have a dramatic change in the way that you clean up your physical environment in the hospital, and you're going to see the effect of that in the occurrence of infection, or better, the occurrence of colonization of bacteria in the surgical theater. Okay, so you take random sample of the surgical theater every day or every other day or every other week and measure over time and see if that colonization, the density and the type of bacteria change as a function of your cleaning. You can do all things like that. If you have a surveillance of anything, a monitoring data on anything, you can do an interrupted time series. The time series equation, by the way, I didn't have the time to go over some of the methods and the step wedge, but I gave you 3 papers in that presentation that shows the model for the step wedge design, just to remind you. Yeah, because it's much simpler and I'm not going to get into the stat too much. I'm giving you how to actually analyze those time series. So you have the data over time. Your Y is your outcome variable. That in this case was prevalence of tobacco. Okay, so it's like average. It's not one person. Each person has a value and have the average. It's the average for a whole city or whole hospital or whole ward of the hospital or whole surgical theater. Okay, so you have kind of an ecological data, but you have it over time, multiple times. The more nuanced, the more detailed information on time you have, the outcome on time, the better your time series. So you got your beta 0, your beta 1t, that's your time. Time is a continuous variable which indicate time in days, months, or years passed from start of the observation period. D is a dummy variable indicating observation collected before or after the policy intervention. So D equals 0 if the Y information was collected before the intervention. And D equal 1 after if it's the data is collected, the Y is presented over time after the intervention. Follow that? So Y is the outcome variable. Let's say prevalence of tobacco. Okay, that's a percentage. 0.1, 0.2, 0.7, 0.9, 1. That's 100%, right? So it's a prevalence estimate. T is a continuous variable, taking month or year. Let's say we're doing that monthly over a 5-year period. So I have 12 by 5, 60 data points. Passed from start of the observation to the end. And then by year 3, there was a policy, a change in policy, very dramatic, that I'm looking at, that's going to affect the outcome. So I mark that on the graph. And then D is a dummy to indicate that Y that I'm measuring, I'm seeing the value here, was measured before the intervention. And 1 is when the D is measured, when the Y was measured after the intervention. P is a continuous variable indicated time passed since the intervention has occurred. That's a different indicator here. So I have one that say T overall from the start of observation period all the way, and I have a P, which is before intervention has occurred, P is equal to 0, and then P after the intervention. It's the value of P itself. So let's see an example here. So you have our data set look like this. You have your Y, okay, whatever is the Y. I don't know. Here's a fake example. It could be a prevalence from 0 to 1, or whatever thing is from values from 2 to 10 in this kind of fake example. Your time is time 1, 2, 3, all the way to 7. There are 7 data periods that data was collected on Y. And then the treatment, D, before the intervention is 0, after the intervention is 1. And P is an indicator variable of time, but it's a little different than the first one. The first one is from 1, that's a continuous, kind of a discrete to treat as continuous variable. Here is really a kind of continuous only after the intervention. So it's a 0, 0, 0, 1, 2, 3. That's a trick to really estimate the effect of the intervention. Combination of D and P is going to give you the true effect of the intervention over time. So we can graphically illustrate each coefficient, gradually build the equation 1.1, which is this equation you saw here. Okay, so you can see the time series, the coefficients. So beta 1 is a pre-intervention slope. Remember, because beta 1 is the T, okay? And then you have policy intervention after that point. Coefficient B0, beta 0, beta 1. If beta 2 equals 0 and beta 3 equals 0, so you know how the coefficient is going to look like. So beta 0 is the effect of 0. Let's say if time is not important and the D is not important, beta 0 is the value of Y. Okay? So here in figure 2, you have beta 1 pre-intervention slope, beta 2 immediate effect. So you see a change in the slope, like I mentioned to you, and it's reflected on the effect of beta 2D, big time, okay? As well as beta 1T. I didn't even put D here. just the B. Here I have another example in which I have the change. So D picks up, D and T together picks up change in the prevalence of at a point in time, dramatically change in intervention. Whereas P really takes up the effect that's slowly changing over time. That's the P, which is 0, 0, 0, then 1, 2, 3, 4, 5. Question, Leonardo. Here. Yeah.
But we know that it's not true. The law is made, and after you have a time for this law to make sense, or it's
Okay, so Leonardo is a student who is present in the classroom. He is saying that we know that this possible drawing F in 1.8 is not true. He thinks it's not true because once you have a policy intervention, it doesn't go like that and go like that. So I'm saying to Leonardo, it is true, Leonardo. Many interventions goes exactly like that. Some don't. So it depends what you're talking about. Okay. In chronic disease prevention, many interventions go like that. Immediate effect, you see an effect, and then a month or 2 months later, zero effect, and then stops, picks up back what it left off, and continue the same trend. After 6 months, you're back to where you were 6 months earlier. So many intervention works like that, especially physical activity or fruit and vegetable stuff like that. That's chronic disease prevention. But infectious disease may not work like that. Infectious disease may work more like that. Okay, so I'm just modeling different types. Okay, so in here, the P is P, the P, beta 3P is going to be 0. P is going to be basically 0. But here, P is very important, and D is not as important. It's really changing over time, little by little. Okay, so by having both a D and a P, you pick up any possible effect. Okay, here I have in this model, once I have a model that includes both, I can pick up something like that. There's an immediate effect plus a continuous effect down, going down. The prevalence slope is going down a little bit. And I need a model that's full like that. However, let's say I draw this model, I program my SAS statistical analysis to build this model, beta 0 plus beta 1 time plus beta 2 dummy variables before and after intervention, beta 3 P with P being a dummy, not a dummy, a semi-continuous variable, 0 before intervention, 1, 2, 3, 4, 1 after intervention. If I do that, if the intervention is exactly like that, okay, P is very important, D is equal to 0. Okay? So the whole thing comes down to 0. But if I do like that, I pick up situation like that. So I need to have this full model to capture the possibility. That's the ideal effect of a policy or a large-scale intervention. I hope you all follow that discussion with Leonardo. It's good to elaborate that all these things are possible. Doing nothing, like here, continue. So it's beta 0, beta 1T. It's only the effect of time. It's a secular trend. Nothing changed. So when I throw that full model, I'm sorry, when I throw that full model here, where is it? This full model, but the truth is this, the other D is going to be 0, P is going to be 0, so beta 2 and beta 3 multiplied by 0 is 0. So you end up just say beta 0, beta 1T. You follow, folks? Go back to your basic linear regression, multivariate linear regression. So that's what this effect is captured by T. So time, the time variable, when you measure the outcomes, itself is the only predictor. It's a secular trend. There are other things causing the prevalence to go up. Okay? Whereas here, something with the intervention happened, but not efficiently. So it happened immediately, but then the slope is the same. In about 5 or 6 months, you're back where you left. So you capture that by D as a short-term effect. Where this one here is a long-term effect, no short-term effect. You capture that by having a dummy for D, a variable that's coded 0 before intervention, and 1, 2, 3 for every point in time. You have Y measured later on. And this full equation also picks up everything if you have a situation like that. You following that, folks? I hope you are. I hope I'm not going too much over the time. So in time series, it's important to understand the counterfactor. Like I said, counterfactor for what would have occurred to Y had the policy intervention not happened. Well, it's captured by beta 1t, beta 0 plus beta 1t, which is time. If you have an equation that only is beta 0 plus beta 1t, express the whole prediction of Y, so you can really predict with almost perfection the Y in the future with that simple equation, then you have your counterfactual. So time is taking care of that. Time is your counterfactual. Let's take a case where our policy intervention, both immediate sustained effect, like I said, the green line is represented by the equation where beta 2, beta 3 are both different from 0, then the full equation captures the effect. Okay? To calculate the counterfactor, we need to assume that the intervention has never occurred. There has been no immediate, no sustained effect. In other words, the policy intervention has not happened. The green line would have continued shown in the first graph. Okay? So if I take the difference between these two, you see these two equations, 1.5, 1.6. What's the difference between them? It's beta 2, 0 and beta 3, 0. Okay, that's the only difference. Because this first one is going to be beta 0, beta 1t, and the next one is going to be beta 0, beta 1t. Because beta 2 and beta 3 are multiplied by 0. Because there's no needed or sustained effect. That's what I was saying before. I'm just repeating, but now showing how this equation works. So 1.5 becomes 1.6 once there's no effect. So the time variable is capturing the secular trend. It's capturing the counterfactual. That's your counterfactor. That's your control group. So sorry for the thing is coming over, but it's the same general idea. You capture that. So if you want to evaluate interventions using time series, interrupted time series, that's what the name comes from. Because after you have the policy, there's some interruption, theoretically, on the time series. If that interruption does not reflect a change in what you're measuring, your Y's does not change over time, there's no real change. It's interrupted and not, you continue the same trend. But if you have immediate change or a long-term change, or a combination of both at the same time, then you have interrupted time series. You see the interruption, the line is going one slope, and it's finishing a level up, then finish lower, start lower again, and then start going down over time. That's a perfect and best expectation for an intervention. Now, tell me, is this as good as a randomized control trial? Leonardo, what do you think? I would say this. In the absence of a randomized control trial, cluster randomized trial, this is pretty decent. There are other methods I'm going to show to you, discontinuity regression in difference in difference. However, this is pretty good, especially and very especially if the time variables capture a lot of the possible confounding and selection bias that could have explained the result you see. If you find no effect, it's actually as good as a randomized control trial. But if you find an effect, if you did not find an effect as good as randomized control trial, but if you find an effect of the intervention, you still have selection bias, you still have confounding. But if your confounding variables are really associated with time, this is pretty good. Let's say your main confounding on I'm doing my intervention in Minnesota, like I mentioned to you, and it's fruits and vegetables or physical inactivity. And I want to increase leisure time physical activity in Minnesota. I know that the cold months are very difficult for people to go out and exercise on the streets, parks, or trails. They don't, unless they are very good at skiing, which very few people are. So there is an issue of confounding and a selection bias intrinsic in that design over a year period or 2 years, whatever period of time, that's related to seasonal changes, okay, related to time. Well, this time series, you capture that. That's your main confounding effect and somehow affect your bias in self-selection into groups of intervention or not, okay? So a time series will do a good job there for that intervention. Not perfect, but it's pretty good. But sometimes it's the only option you have, and you have many, many, many sources of data time series. Look no longer than your public health surveillance systems in every state in Brazil. For infectious diseases, it's pretty old and pretty decent. How do I know it's old and decent? Why I say decent? In 1987, I was looking through data and computers already in the city of Recife, Prefeitura do Recife. That's what they said about it. That's Portuguese now. Okay, 13th floor, Secretaria de Saúde, Secretariat of Health, Data Prep from Rio de Janeiro had the data all digitalized for infectious disease all over the state of Pernambuco, the city of Recife, the city of Paulista, city of Olinda. Data Prep, Rio de Janeiro, a few months later. So if back 35 years ago, they already have that, they should have even better data now. People just don't use it. Okay? Again, a little bit more counterfactual. We can calculate the counterfactual for each point in time, as I mentioned to you, because you have this expected trend line. The time is the only thing that you have to allow you to see what would have been. So even if you have the data showing effect, but if you only have time as a predictor, you're not going to see that effect. You're going to see that time it's just predicting a continuation, right? So your prediction will change after you introduce the other variables, and then you can calculate the difference between the equation, and then obtain the change for each point in time, T10, T18, T20, and the future. And you can predict if you see the slope after the intervention comes down substantially over time, and the beta zero, the point where the value for the prevalence of tobacco start changing over time, right? So you can see that the difference between these 2 points, that's your counterfactual. Okay? So students' well-being data set contains 365 daily observation well-being of a class of students. Well-being is measured by an index from 0 to 300. At time at T equal 201, student will start attending a mental health education class. We want to understand how and if their well-being improves. Here's kind of a fixed data set that I created. Okay. This is plot of the well-being by time, marking start of treatment. So what do you see here, folks? The y-axis is the well-being index from 0 to 300, and here times 0, 100, 201, 300, and 400. That's what the well-being class. Remember, I say at time t equal 201, I start having the intervention. You can see that the well-being changed. The slope is beginning to change to become, it's positive, but slightly positive becomes more positive. So there's a time trend going up already. But then the slope goes up a little bit higher, it's more steep incline, and the initial slope, that's a value of beta zero when everything is, it's when the other variable is up zero, it goes up from 70 to about 80. You see that, the little difference between them? So well-being, time, treatment, time since, oh, I'm sorry. This is causing me some real trouble here. Sorry for that. Give me a second. I'll fix this. I'm so sorry, folks. Jesus Christ. I don't know what's going on here. Well, it doesn't want to go. Let me see. I still can read this. I'm sorry, but I just fixed as much as I could. I don't know how they're coming on the top of each other. So here you have a little box that tells what the variables are, the description of the variable, like I said before. Model is based on a simple equation, beta zero, which is y in time, treatment, and interaction between time and treatment is equal to 0. So that's beta 0. Okay, and you have an error term. It's called equation 2.1. So it's a very simple model here. It's a variation of the original model I showed you for time series. Okay. So here you have the results on assess analysis of that. You can see the model results for time, the beta 1, beta 2 for treatment, beta 3 for treatment and time, and then a constant. That's your beta 0. Okay. So here's the p-values. The stars means 1 star is 0.05, 2 stars 0.01, and 3 stars 0.001 or less. The time coefficient indicates well-being trend before the intervention. That's your time, 0.19. That's a trend up. It is positive and significant, indicating students' well-being increase over time. For each day that passed, the well-being increase 0.19 points. Okay. The treatment coefficient indicates the increase in the student well-being immediately after the intervention. We can see that immediate effect is positive and significant, indicating that pain in the first class increased the student's well-being of 13.09. That's that change in the line, a little change from one line point to another one a little bit higher. And then the time since treatment's a mix of the two. Okay. Coefficient indicates the trend had changed after the intervention. It's an interaction between time and treatment. You throw that in a model as an interaction term, multiplying your time variable by your treatment variable. Okay. The sustained effect is positive and significant. This is the equivalent of that P early on that I mentioned to you. That P, I either create a variable called 0, up to the intervention, then 1, 2, 3, 4, like imitating time, or I multiply the treatment variable by the time variable. Okay, you give the same as the same idea of modeling. So this model here, instead of beta 0, beta 1 time, beta 2 treatment, beta 3 becomes beta 3p. Remember p early on is this time since treatment, right? I can do that by multiplying beta 3 by p of new variable, indicate time treatment, or an interaction between time and treatment. So here again, oh my God, I'm so sorry, folks. It's, man, give me a second. Okay. Sorry. So here now we can calculate the outcome 30 days after the intervention. Can predict, okay? Time will be equal to 230, while time since treatment will be equal to 30. Treatment is always equal to 1 since it's a dummy variable indicated pre and post intervention. Treatment here is the same as D early on. Just remember, so I'm using different terminology to follow what's in different books and paper, but they mean the same thing. We can add the new point at T equal to 30 to predict what the value is going to be. You see that? You say beta 3 over 30, beta 2 multiplied by 1, beta 1 to 230. You already have the values for beta 1, beta 2, beta 3 here. Okay, 0.19, 13.09, and 0.54. So then you can tell what the well-being, is what the outcome variable to well-being is going to be. Again, sorry for that. Give me a second. I'll fix that. As they're all coming like that. I'm so sorry. So using the same mechanism illustrated in the previous drawing, you can calculate a counterfactor at any point in time. The counterfactor to time to 30 is going to be, if beta 2 is equal to 0 and beta 3 equals 0, what's going to be the value of beta 1 to 30? That's your counterfactual. You find that value and you take the difference between the value you have for the full model minus that value. It's going to give you the counterfactual. How much of the effect is attributed to the counterfactor, not to your intervention. So not only you calculate an intervention effect, you can predict and measure what the counterfactual is. Okay? So again, the same ideas behind, I'm so sorry, we're nearly there. I told you to be 12, 20, it's nearly there. Let me see. Counterfactual varies for each point in time. Yes, it does. You can see that closer to the point where the intervention took place, it's smaller, okay, at point 230, it's smaller. The counterfactors, the C and the Y, is your predicted value based on your equation. So the difference between the two is going to give you the value. But over time, because this intervention is going stronger in a positive, if I remember, its well-being measured by an index from 0 to 300 is going up. The well-being is going up over time. So the counterfactor become more and more distant. Okay, but the counterfactor is measuring the initial line that you predicted. You see that if you trace a straight line on the pre-intervention, that line is going to go through the counterfactor 230 and the counterfactor 320. So the counterfactor's time alone is predicting that. Okay, and you can measure the difference. Say this is the counterfactor that I would have had over time, and therefore this is my true effect. It's the difference between y value at t to 320 divided by the y value at c equal at 320. That's the effect of your intervention. Finally, we can look at the result by plotting all predicted outcomes and their counterfactuals, all of them. You can program your computer to do that, and that's going to be your delta, your effect of the program. It's important to see delay effect and time series, not the coefficient obtained from a equation. Do not tell us the difference between each point and counterfactual statistically significant. Just tell there's a difference. There's no statistical test to look whether the difference between predicted outcome and counterfactor is significant. There's no. And the implication for that is that it could be the effect intervention varies over time. We don't know because I'm using a prediction. What if something is happening over time that's going to affect the intervention and the effect of that intervention? I don't know. I can only predict and estimate what's coming ahead. In this case, there's a drop. For instance, in this case, there's a drop in the students' well-being right after the intervention. For instance, it could be that class challenges students to think about their emotion, thereby increasing the overall sense of well-being. So that's a completely different effect that you would expect it. And you may miss that by series, but you may also capture that. It's up to. So I want you to pay attention to these graphs and send me a question if you have any. But I think it's pretty obvious what the time series is doing. In the absence of a true control group that's randomized, and by doing randomization, control for selection and confounding bias. Remember, there was a lecture early on that I gave you. I did not present much about it, but I gave exceptionally good material about measurement errors. Read that lecture, understand selection biases in observation and experimental design, as well as confounding. So a randomization takes care of a lot of problems. You render the intervention and control groups similar in everything except the intervention. Therefore, if there's a change in the outcome, you attribute that to the intervention or treatment. Whereas in the quasi-experimental or observational design, you don't have that. You have proxies for control groups which are not perfect in a quasi-experiment. And some of the quasi-experiment, like this one, is more like an observational design of the surveillance systems or any other monitoring system. You have the counterfactor estimated by trend on time only. Okay? I think this is an important example of how to evaluate long-term policies and intervention in public health. I want you to use it, and I'm giving to you. There's a lot of reference and citation in there, and I want you to pay attention to. I want to review those before I leave São Paulo, so that the reference, because it looks like some of those citation references didn't come through. Well, most of that time series coming from this citation, but there are other citations. I'll add those to the presentation. Okay, folks? You'll be a wonderful audience because you're not here except for Leonardo and Luis asking questions, but they were good questions. Thank you. We're on time. We're about 12:20. And sorry for the technical problems in the middle. and for starting the lecture 30 minutes later for on an unexpected event that I had to take care of. Thank you all for this. Take care. See you tomorrow. We're going to do difference in difference, regression, discontinuity. Oh, not tomorrow. Thursday and Friday. Oh, that's true. Okay. So tomorrow there's no lecture. It's a Thursday and then Friday. Yeah. Please come. There will be a webinar on diabetes and metabolic syndrome at what 2 p.m. tomorrow. It should be announced. Fred will send out the announcement again to all of you. Okay? Please come. It's very interesting. I have a lot of stuff there. Totally different than what we're doing here. It's more about this condition anyway. Thank you. Take care, folks.